Good evening, ladies and gentlemen, and welcome to the Australian Dental Association New South Wales Branch General Meeting 2013. Tonight we've got a great occasion where we're going to be discussing how relevant is the dental profession to the general public. And to assist us with that, we've got two speakers of note. Dr. John Hewson AM. John, who is an Australian economist, company director and former politician. He was federal leader of the Liberal Party of Australia from 1990 to 1994 and led the party to defeat at the 1993 federal election. He was educated at Kogarah High School. He then attended the University of Sydney, where he graduated in economics. He then gained a master's degree from the University of Saskatchewan and a second master's and doctorate in economics from Johns Hopkins University in Baltimore. We're also privileged to have John Della Bosca. John, who is a former Australian politician representing the Australian Labor Party in the New South Wales Legislative Council. From 1999 to 2009, John served a range of ministerial portfolios, including Minister for Health and Minister for the Central Coast in the New South Wales State Government. In July 2010, John resigned from the New South Wales Legislative Council to become a campaign director for the National Disability and Carers Alliance and assist in the establishment of the National Disability Insurance Scheme. Also privileged to have Professor Clive Wright as our moderator, and Clive's no stranger to dentistry, having been the past Chief Dental Officer of New South Wales. He's held senior appointments with both the Dental Health Services Victoria and New South Wales Department of Health. He's the recipient of several National Health and Medical Research Council grants into oral health and has led a lot of the research into fluoridation. The format for this evening is that we are going to ask each panellist to introduce their perspective on the question, how relevant is the dental profession to the general public? And we're going to then work through this to get a sense of what does the future look like for the profession and the public. So thank you to John and Clive.
Thank you very much, Matthew. Well, you heard the question, how relevant is the dental profession to the general public? Well, in the past 6 years, dentistry has been on a roller coaster. We've had the chronic Medicare, Commonwealth, chronic dental disease scheme, which has been on and off again. Finally being switched completely off in December of last year. The Commonwealth appears to have plenty of funding. We've had replacements offers in the 2012 budget of 2.7 million for around 3.4 million Australian children who will be eligible for subsidised dental care. That's the Grow Up Smiling dental program. Another 1.3 billion will be spent on 1.4 million additional services for adults on low incomes. This will include pensioners and concession card holders and those with special needs. Another 225 million has been budgeted for dental capital and workforce initiatives, which will be provided to support expanded services for people living in outer metropolitan, in regional and rural areas of Australia. Apart from funding, we've had issues, big policy issues on the professions such as the Australian Health Practitioners Regulatory Framework, which has been new for us, definitions of the scope of practice, dental practice, accreditation of dental practices, dental workforce planning, and all of these funding and policy issues have put pressures on the dental profession and the relationships with the general public. The state government, on the other hand, has really looked more purely at its constitutional service delivery role and been more concerned about ensuring that the funding it gets from the Commonwealth is appropriate and it meets all the general ticks that are required under a national partnership agreement. So who is really responsible for turning around the structural and attitudinal aspects of improving oral health for Australians across the myriad of different public interest groups and across so many and varied different communities within our Australian population. And while individual responsibility is often at the heart of policy differences in approach, if oral health and oral health care is not totally a personal responsibility, and if it's not totally a government responsibility, what obligations does the dental profession have, and what should it be trying to evolve in mechanisms and processes to improve the oral health of the general public, and especially of those most in need of dental care, and not necessarily those that just want or desire dental care. Dentists in the dental profession have been astonishingly sidelined, really, from the key policies decisions which impact on services to our patients and the ways of improving public oral health. And we wonder where we've gone wrong. What is it about being a dentist which puts us on the sideline and not part of the main game in the one area, dentistry, that we have been educated and trained to understand? Our national leadership, that's the ADA Inc., has been tirelessly in extolling the virtues of the Dental Access Program as a solution to public dental health services, and our relentless cautioning of the Commonwealth in its exuberant expansion of dental schools and oral health therapy schools. Are these policies capturing the values and wants of the public and policy makers, or are they perceived as being out of step with public perceptions? A recent paper by a University of Sydney team investigating relationships of patients and what they value, dental patients value, found that patients valued having a supportive and caring dentist and a dedicated dental team. The experience of having a dedicated, supportive and caring dentist helped patients to take control over their own oral health, as well as being able to find their way through their relationship with the dental profession. Now, looking around the room this evening, you can see that we have all, or not all, there's many more out there that are dedicated, that are supporting and caring dentists. Yet the social media continue to portray attending a dentist as being fearful, as being costly, and avoid if you can behaviour. What can the dental profession do with the general public to counter these negative stereotypes? Well, John Hewson, John Della Bosca, we're all eagerly awaiting your advice on these and other matters and issues of importance to the profession and to this branch. So perhaps I can call on John Hewson first to respond to the question before us.
Well, thank you very much. Good evening. Thank you very much for having me. I don't know an awful lot about dentistry except as a patient, but I've had a fair bit of experience, I guess, in government on both sides, and in dealing with these sorts of issues, I see the dental profession in a similar position to so many other professions and industries and so on in this country, being unsure how to actually position themselves, not only in terms of the public perception, but also in terms of how to live with and operate with governments around this country. And that's not an easy thing to do in current circumstances where the political process seems to have moved away from issues and problem solving and more into games and scoring points and character assassination and things like that. So it's very difficult to get heard on substantive issues. And at the same time, you have, I think, very significant shifts in the attitudes of the electorate of patients towards the profession itself. I mean, you've summarised it, Clive, by saying you're seen as expensive, must do and I have to sort of thing, but I don't particularly want to go if I can avoid it. And that's clearly not an ideal situation for a country which has a major issue in terms of dental health, oral health. John next to me has spent a lot of time in disability care in recent days, and We now have a national disability care program. Still a long way from being defined, and even further probably from being funded. And it's going to cost a lot of money. I think the numbers that I see in the 2020s are of the order of $20 to $30 billion a year. Yet we don't actually know how big that program will be and how long it's going to take to get there and so on. It's very similar if you look at the issue of oral health. I mean, there are proposals around for a national dental scheme. And I guess to go back to the point you made at the start, there have been so many attempts by governments at both state and federal level to cut and paste in relation to the dental profession that I tend to think at some point you have to step back from all that. It's very hard to make yet another marginal change or advocate yet another set of circumstances. I think you sometimes have to step back and say, look, if we had a blank piece of paper and we were to attempt to define the sort of structure we'd like to see, the relationship we'd like to see between our industry and the patient, our industry and the government and so on, and then specify it out in those terms, and then come back and see what changes you need to make to get from where we are today, which is a bit of a mess, as you said, has been cut and pasted several times, to how you get to that ideal. That's probably the most productive way to go. And then once you've got that pure strategy, pure concept in your head as an operational strategy, then you work out how best to deliver that in terms of working with government advocacy and government, raising your profile with the community, educating the community and so on. And as easy as that is to say, it's quite a hard thing, I think, for the industry to come together to do, particularly with a federated body and all the other constraints that we have in operating in this country. So I think it's a very important issue. I think to answer the simple question, it is extremely relevant, but it's not handled very well at most levels, either at the patient level, the community awareness level, at the professions level and in government.
Okay, some simple mechanisms that you would suggest, though, to try and get people around a table to, you talked about a greenfield kind of approach there?
Well, in my experience, you're better to have a relatively small group of people to define that strategy in the first place. If you're going to start with a blank piece of paper approach, and that's a very difficult, there are a lot of layers to this problem, as you've pointed out in your opening remarks. Getting that balance right. I mean, on one hand, one extreme, you see yourselves as a particular profession with particular standards and skill sets and practices. Yet there are people out there that don't want to see you as a profession, and governments tend to look at you as having a social responsibility to take care of the disadvantaged and the most needy in particular, how that ever is defined. I think from an industry point of view, you're better to do your own defining. Because if you don't define some of those areas, they'll get defined for you, and you end up with a piece of legislation through its manifestations of state and federal debates as well that ends up giving you what you don't want or what you never thought you'd end up with. And we've seen that in so many cases in the last decade in particular, not so much earlier on perhaps, but in recent years where policy hasn't been an important process and where the game of politics has increasingly become a 24-hour media game. I mean, the detail of those issues gets lost in a parliamentary committee process, public debate and so on. And so it takes not only getting your vision of what you'd like the position of the industry to be correct, but also to have a strategy for getting that delivered. You've seen some very activist industry groups in recent years have run various strategies to achieve that. I mean, the mining industry said, fine, we'll fix you, we'll spend $100 million, we'll make your life miserable, so you better give us what we want. That's an extreme case, but you saw it in terms of the big polluters and carbon pricing. You've seen it in so many areas across so many years now. But you've got to have a strategy for handling that and determine your most effective way. I think education is such a big part, and I think you've spent a lot of time in your life, Clive, on fluoridation. I'm fascinated that there's still something like a quarter of the Australian population that don't have access to fluoridated water. So, I mean, you've got to say to yourself, wouldn't you basically start there? And then wouldn't you go to school programs? And, there's structures you can put in place. But it's a big job for an industry to rethink itself. And that's why I go back to the blank piece of paper approach, that set aside all your past thinking, if you like, and start afresh. in terms of today's world as to where you think you want to be, and then strategise about how best to achieve it. And I'd start by defining that where you want to be with a relatively small group of professionals from within the industry and with some outside perhaps advice, and then work on the delivery strategy of that.
Great. John De La Bosco, what's your take on this and our relationships with the general public?
Well, I suppose if I was starting, it is a bit like the old Irish joke. If I was trying to get to Dublin, I wouldn't be starting out from here. But
Yes.
but if you look at the current situation, there's a couple of essential principles you can apply. I think the first one is that, and John really alluded to this, that most people in government, other than the fact they have a dentist themselves that they go and see, and that's an important point to remember. One thing that Julia Gillard and Kevin Rudd and Tony Abbott all have in common is they've all got a dentist. Tony's a bit different because he's actually got a family, a couple of people in his family who are dentists, but dental care is ubiquitous. It is something you can, and so on one hand, the problem is that means it gets taken for granted. On the other hand, the potential is, if you get the message right, that people will respond to the fact that yes, they know they need a dentist. That people have to have dentists. There's dentists everywhere. So I suppose my first point about talking to government in particular, whether it's the Commonwealth, the state, or for that matter local government, is stick to your knitting. Dentistry has got a lot of credibility when it's about dentistry, and it might sound like a stupid thing to say, but there are a hell of a lot of people that make the mistake when they go to talk to government to talk about everything else except the thing that they know most about. Mm-hmm. And they can couch their arguments, whatever they might be, in terms of the sustainability of practices, regulatory issues around scope of practice, whatever else it is from the knowledge base of being dentists. So it sounds simple, but people often forget that basic principle that there's an authority that comes from the learning that people have to undertake, or the university education. Should describe it as university education, sound like Tom Sawyer, but the university educations that people have had to have the work they've done to be recognised and be credentialed as dentists. So that's the first thing. And enormous number of people, enormous number of groups make the mistake of doing either having a whole plum pudding of things because they think to be relevant they've got to look as though they're covering the field, whereas in fact most politicians, governments, even bureaucrats kind of think, well, I cover the field, that's my job. I want to hear the special thing that a group of people know. The second thing, which I talked a lot to Shane about, and a few other people in the room, Bill and other people, is I've got a theory, and I've used it with John before, and I hope he agrees. He might not agree today, but the big thing now, because of spin, because of dissociation, disconnection from the political process, not only by people that are perhaps less educated, but by pretty well everybody, is that, and the creation in Australia of what we didn't have any significant way 20 years ago, of a beltway class, a political class that live in not necessarily live in Canberra, but are Canberra focused, and I suppose what that has created, amongst other things, is a sense in the media and in the culture that nobody has a motivation except their own interests. Now, because dentists are people who, if they run a successful practice, can obviously, run a successful practice, earn fees, do quite well, they are very vulnerable as a group and as individuals to the idea that whatever they prop up and say about dentistry or for that matter about oral health in general or bigger health questions is all about the fact that they're trying to line their own pockets. Now, doctors seem to have somehow, they used to have that problem, but somehow doctors, medical doctors I mean of course, have less and less that problem in when they get into the public realm. But I'll leave you to contemplate on why that might be so, because I don't want to get into trouble with other people, and just sticking to the issues around dentistry and the ADA. It seems to me that the ADA has a lot of evidence, and individual dentists have a lot of evidence, that dentistry is a well-motivated profession. And we were talking about one during John's presentation. That is, the obvious one. You can't get more well motivated than to be advocating something that's actually doing you out of a job, which, I know I'm exaggerating the point, but that's essentially the consequence of a population that has access to fluoridated water from infancy on. There'll be less need for drill and fill type dentistry. Now I know that most dentists are happy and content to look at other kinds of dental clinical work that they'd be interested in their practices, but it's an interesting point. As long as I've known it, as long as I've lived in this country, well, I've lived in this country all of my life, of course. As long as I've been here, I know that dentists, as a group and individually, have advocated the fluoridation of water pretty well without exception. And yet, as I said, I think a simple thing that anyone can understand is dentists are out there advocating something because it's good for your health. One of the consequences of it is they'll get less work. That was an important thing about the NDIS. It's sort of one of the winning points was that a lot of the people most strongly advocating for an NDIS were the service providers who are actually having their lives made a lot more difficult and maybe even in some cases not even able to survive in an environment with an NDIS, because the motivation was they wanted the best for people living with a disability, and dentists want the best for their patients. So I think that's another thing. Too obvious. Obviously you think that you're only in the game doing the best for your patients. Regrettably, many people out there are quite happy to say, no, he or she's in it to drive the BMW or to XYZ, do whatever other thing that you might want to do or be able to do. So that's I think a key point. Motivation. Why are we motivated to do this? So it doesn't matter whether you're addressing the issues around dental regulatory issues, whether you're addressing the issues around new schemes that support. And in fact, another thing which you could, I think, advocate, and the point was again made, though as I said, we're trying to get to Dublin from here, but the other point I think is well worth making is that a lot of the best elements of the new changes to the dental arrangements in the Commonwealth are actually the result of advocacy by the ADA. So I think it's a kind of all care, no responsibility. The things that the ADA advocated are very good aspects of the scheme. Other things you can blame someone else for. But basically, I won't say someone else is. But basically, I think that's another point about motive. We're doing this because we think that we need a better scheme that looks after people and looks after dental health. I think the fourth point about it is almost universal relevance. I think dental care is like, having access to quality dental care for a population. It's a bit like having, obviously fresh water or clean water and access to nutrition and access to a basic and literacy and numeracy. Dental health care is one of the essentials of life if you want to have a comfortable and healthy life. And I think, it's worthwhile making that point, because a lot of people, even though they go to dentists themselves, don't realise the cumulative effect on their health or their children's health or their aged parents' health if they didn't have a dentist looking after their oral health, what the health consequences would be. So it's worthwhile, I think, in every occasion that's available, reminding people of that. I think the other thing, and I'll conclude on this point, is that it follows on from the point about motivation, and that is that increasingly, I make when I first started when I first became involved in partisan politics, I was young. My grandmother would say, like being a good billiards player, being good at political campaigning is a sign of a wasted youth. But I think the point here is that when I first started in politics, and when John first became active in politics, and when a lot of people were probably thinking when they were at least some of the people here when they were at uni, thinking back in the world that we lived in, the Australia we lived in, well, 45% of people were coalition voters, and 45% of people were Labor voters, and 10% of people, and 2% of people were Communist Party voters, and 2% of people were Australia Party voters, whoever the other people were, and a very small minority of people were the strange beast we used to call swing voters. And that meant that politics had a certain flavour and character about it, certainly at a national level and also at a state level. That's completely changed now. That is a framework, although people still talk as if it's still there. That framework is gone. It's been gone for at least a decade, probably 20 years. And politics is much more like, there's probably 20% of the population now that vote Labor habitually because they believe in the Labor Party principles or cause, and probably maybe 15%, maybe 20% who vote for the various for Labor, for Liberals or Nationals because they believe in the cultures of those belief systems. Everybody else, they might as well be in Woolworths, shopping, taking off the shelf what they like or don't like, and throwing away what they don't like, or taking back what they don't like. And I think that we have to adjust our political thinking and the way we get policies across. And the great opportunity for the ADA, and the great opportunity for organisations like the ADA, and for individuals for that matter, is that people don't, this is an irony, but people don't look to parties for policies anymore. They don't. They've given up. They don't think that political parties are about policy. Because policies are about hard choices. People don't advocate hard choices. They advocate soft choices, and then they end up having to prevaricate to do the various things. So it is you can actually, if you get yourself, you stick to your knitting, if you make sure you've always got a negotiable position, and if you always make sure that people understand your motive is a benign one, is a good one, is a socially positive one, then you can actually take the place in the field that you want to get involved in of political parties. You can actually develop policies, advocated the right way, they'll become the policies that are part of the body politic, because these days it's pretty hard to get parties to the barrier when it comes to real policies. That's my thoughts.
Mm-hmm.
I think, if I could just pick up on one thing, I think it's a very important challenge to the profession, is to understand why, when you were so self-effacing, so operating so much against your interests with fluoridation, that you didn't get the public credit and recognition for that.
Yeah.
I think it's a very big point to actually address as to why didn't we get it when we've done perhaps more than any others. I mean, John's right. I mean, today people, vested interests, everybody reeks of vested interests, and they are entering an auction to some extent in Woolworths, where you're offering their, trying to get their best, buy your vote or buy your support. And here you've done something which is visibly against your best interests.
Yeah.
And related to that is a perception, I think, out there realistically, that you're seen as pretty exclusive, pretty, you use the example of BMW driving. But
sorry, you probably drive a BMW.
No, I don't. No, it's one car I don't have. No, you're seen as exclusive. You're seen as restricting the number of dentists, of keeping the price up, of charging excessive prices, of being very expensive. And that perception is on the back of the fact that you were so self-effacing and operating so much against your best. It's very difficult to understand, but I mean, that's where you've got to understand. You've got to start by trying to address how did that happen, and why haven't we got credit for what we've done? And because when it comes to you then offering to help the disadvantaged, people have got to believe you're actually serious about that, that you can deliver that, or that you want to deliver that. You don't want to still charge, $8,000 for a set of braces or whatever it is.
Yeah, I think you've both raised some really interesting issues, and I like the analogy, stick with your knitting. I also like the split, the 40 to 45% kind of rule that was in the past, because when we're looking at what we would call our mainstream dental market, we're really only looking at 45% of the population that regularly would use dental services, whereas the rest of the population are pretty irregular users. So coming back to your discussion of the impact that water fluoridation has been actually fantastic for probably our 45% that we regularly see. And then we've been able to add value in their mouths by moving into orthodontics, by moving into cosmetic dentistry, by moving into implants. But what do we know about those communities? Talked a little bit about the disability community. What do we know about those other communities that don't regularly attend a dentist, use our dental services, and what can we do to assist them in moving towards more regular attendance, looking after their own oral health?
Just to make a point on numbers, I think the 45% you say that regularly use dental services, there's the 55% out there that don't. That's a bigger number in terms of its relative significance than the number of disabled in this country.
Yes.
Yet we've been able to get a disability care structure, at least in principle, in place. I mean, I would think that oral health and so on is at least as significant a national objective as disability care. And, you know, so that's the background against which you operate.
So the impact of this election, which we understand should be coming up sometime this year, marginal
November.
seats, Sydney West, Western Sydney, very important areas, and these are relatively low income areas. Their dental attendance, if you look at the spread of attendance, would be lower. Their capacity, their disposable income to purchase dental services might be lower. They mightn't even get on to waiting lists, for example, in the public sector. So how is there any mechanism of generating some sort of interest, relationship with those sorts of groups to allow the profession to develop its goals and objectives?
One of the sorry, John,
Go ahead.
but one of the issues around that kind of development of a policy position by the ADA, by dentists at large, is elections are not a great climate for doing it, unless there's an opportunistic kind of issue that spills out that's raised by one of the parties, or somehow it comes into the arena. There's so much competition. If you like, it's the worst time to be, it's the worst time to be selling your product, because everybody's got a product. It's a marketplace. Everybody's out there flogging. As John said, the Minerals Council will be out there with a view on something, spending $100 million advocating it. Somebody else will be having their view, and the ADA, amongst others, could easily get lost in that. I think it's better to create the opportunity of a sustainable kind of position, which may still be present in an election, but it's not, you're not trying to win or lose the election. I think the other thing is that myself and a few others probably would lay claim to, if not inventing, at least having a lot to do with the engineering of the thing we call marginal seat campaigning, which has now become a cult in Australian politics. And look, I mean, it's basically a false science. So that probably people keep developing clever and clever ways of doing it. But the parties themselves are doing it, and it's very hard for you, by you I mean ADA, AMA, any other group, to get into that one way or the other. And also, it's a good way to sort of make enemies, because it's a zero-sum threat, isn't it? We're gonna campaign against these 10 people. I mean, you've got to be really certain that you want to get rid of those 10 people, and that you're going to get rid of them, because if they survive. So that's my thoughts.
Yeah.
I agree on the comment about trying to win these arguments in an election campaign. Unless you've got get one of the major parties to say embrace a policy objective, they'd call it a policy. As these days, policies are little more than dot points on a page. They're not actually much more detailed. But if it was affordable healthcare for everyone, sort of thing, and they were committed to that and they were fighting for that, prepared to argue for it, I think you'd get lost in the melee that is an election campaign. And it's unlikely that you'll get that. I mean, you got something like it with the Greens, making it a condition of the deal with the government that there was something done on dental health in this country, some sort of move towards a national scheme, not well defined and not well implemented as it happened. But electoral campaigns are very, very difficult places to win those points. But it's the slow grind, because you're going to have to win over time the bureaucracy, as well as a substantial body politic, to actually make it happen.
Right. Do you think we can move on now and take some questions from the floor?
Sure.
All right, I think we've got a question from Dr. Brendan White, who's the first cab off the rank here. Brendan.
Thanks very much. Certainly, both speakers have addressed part of my question, but the role of professional associations has evolved and changed considerably over the last 10 or 20 years, especially in relation to advocacy and lobbying. In your experience, what do effective associations do that others don't, and what is it that separates the good from the bad?
Well, have you got that one?
Look, yes, I've got it. I don't know. I'll have a crack at it, and I'm sure John will have a crack at it as well, if that's all right. Look, I think it's very hard to sort of say what works and what doesn't, because something that works one time will obviously be a complete dead duck the next time, basically because politics is it's a strategic game. People don't like it when you use the term game, but it's a strategic game in every sense of it. In that there's opposing camps, and in the context we're talking about, there's multiple opposing camps, and people change their actions based on the anticipation of what their opponent will do. Sometimes they get that right, sometimes they get it wrong, and when they get it wrong, they usually lose very badly. When they get it right, they might pull off an unexpected win. Those are the kinds of realities that happen on almost a daily, if not a weekly basis in a political campaign, and they happen over time in party partisan politics, from one parliamentary sitting to the next. But I suppose I think I would think the ADA has done pretty well in the context of other organisations at getting a position put forward. I think the organisations that do well are those that refrain from being shrill. Unless
you've got $100 million.
Yeah, unless you're $100 million. Because I'll hand it over to John now, but I just make the point as well as the other things I said. I think one of the things that drives you nuts as a politician is the number of people that are angry at you for no good reason. And they come into your office and yell at you, and you smile because you have to, and you nod and you say thank you very much, and then when they leave, you tell your secretary never ever to make another meeting with them again. You have to have the patience to make your case in a positive way, and that's hard. And it's hard to get heard when you're doing that, but it's the only way to do it, because if you make it in a shrill way, people disregard it.
Yeah, look, I don't think there's any general answer, and I don't think there's any particular silver bullet, but it does depend pretty much on having a substantive strategy. I think it depends on your capacity then to seize the moment, take an opportunity, create an opportunity to get that implemented. I'll give you a specific example. When I was head of the Arthritis Foundation and Osteoporosis Australia, how on earth do we get recognised? These are the diseases that nobody wants to know about, but they have such a tremendous impact on the lives of people going forward. And so I looked at then the national health priorities, and there were 5 national health priorities. There were heart and arthritis, heart and diabetes and asthma and so on. And I thought, ours is far more significant than that. How do I make this point? So I commissioned Access Economics to do me a study of the significance of musculoskeletal diseases. And their conclusion was it's the equivalent of a mini recession in this country. About between 1 in 3 and 1 in 6 people are affected, so on. So I had my substantive argument. I then needed to have a strategy to implement it. Talking a bit against ourselves, I waited till towards the end of a parliamentary term when I knew that there was some excess cash in the health budget. I knew the health minister quite well because he used to work for me. So I went to see him and I said, how is it that you're going to hit my people, sort of between 3 and 6 million of them, when you've got only 800,000 with diabetes and 900,000 with asthma and so on? We ought to be a national health priority. And we won the argument and so used the opportunity to turn, but it had a substantive argument, put it the study on the table, and then I took the opportunity that I part graded and part seized and said, okay, this is how it's got to be done. And so when I look at the successful ones, they've had substance, they've stayed with their professional, they've stayed with the knitting, they've had substance, they've built a strategy around it, and then they've taken an opportunity or created an opportunity to implement it. And you could say the same about the mining lobby, Mining Minerals Council. They knew the government was on the ropes and running into that last election. And Gillard had about 3 weeks to actually settle the issue. Right, we'll spend 100 million, you've got to give me this, and the deal was done. The government went out and tried to sell that as clever negotiating. But the fact is that that's what you've got to do to maximise. But you never give up what you stand for, what you believe in, what your principles are, because you can win on that, but you need the strategy around it, the opportunity to achieve it.
Great, some good ideas there. And we've also got our first online question coming to you. We don't know who it's from. It's anonymous, and it's to you, Dr. Hewson. Dr. Hewson stated that the profession has never received favourable recognition for fluoridation initiatives. Who should be providing the accolades, and how do you influence a cynical public with a very short memory about your true motivation without constant hassling and a great financial cost?
There's no easy answer to that question, obviously. It's a multifaceted issue. The point I was making is that you need to ask yourself, why didn't we get the credit for what we did? And you did it over a long period of time. It's a process that's been running quite a number of decades. And it's still, as I said, not done, because only 75% of people have got access to fluoridated water. So it's a process that's still running. I guess you haven't marketed that, and you haven't explained that, and you haven't educated people about the significance of that, when at the same time you're competing with the other assessment that I gave of you being very elitist and expensive and so on. And that comes back, I guess, to your basic education communication strategy. And there are no simple answers to how you improve that. I mean, I think generations have passed since that process started who wouldn't know anything about what's in the water and what benefit it is to their teeth.
A little bit like vaccination processes too, and you would have found that, and
you'll always get the rearguard action as you're getting on vaccination today, that there's medical evidence in quotes emerging to say that it's, you know, it compounds the problem, that it increases the probability of you catching these diseases, blah blah blah, trying to undo the benefit of what have been decades of a very successful program. So you always need to deal with that minority.
Ongoing education and commitment. We have another question from the floor. It's from Dr. Murray Thomas. Murray.
Hi, Murray Thomas from the ACT, Private Dental Practitioner, and I am here to help you from Canberra. Often used but never realised. If we look at the funding of public dental health particularly, and it is spread across the three levels of government, and we know that there is quite a groundswell from the community for a demand for expanding dental services. If we sort of look in the crystal ball, in 10 years' time, where do you see government funding sitting or possibly sitting?
Well, I think we are in a very difficult set of financial circumstances, which I personally believe that our federation as we know it is pretty much on a cliff in a financial sense. That the financial demands that are being made on governments at all levels are nowhere near, or the expectations that have been set about what services government should provide across the board are not being matched by the financial capacity of those three levels of government together to meet them. And it's getting worse. And you see it in the last budget, for example, that there's a $25 billion infrastructure program announced over the next few years. Only $3 billion of that is committed actually in the budget, but $25 billion is announced. And a lot of the $25 billion depends on the states being able to match their share or contribute a financial percentage to the cost of a program. For example, the Melbourne Metro, which is going to cost about $8 billion, the current numbers, the expectation is the Commonwealth will fund its part of that if the state of Victoria funds $3 billion of it. Now they're never going to find the $3 billion, so it's noise. It's not going to happen. The link between the F3 and the M7, M2, sorry, M2, M7. The condition that the federal government puts on that is it can't be a toll road. Yet the modelling in New South Wales is the only way it's ever going to be built if it is a toll road. So there are games being played about numbers, but the expectations of infrastructure requirements, that's, you go hospitals, schools, roads, all the way through, ports, and then add to that national disability, Gonski and a whole host of it. There are tens of billions, if not hundreds of billions of unfunded expectations out there that cannot be delivered. And I think what you're going to see over time is that's going to become increasingly evident. In state government terms, expenditure on services like health, which are fundamental services of a state government in a delivery sense, are running, the costs of those are running about twice what the revenue base is increasing by. So inevitably the percentage of the budget that goes to health almost starts to consume the budget. So we need to rethink the whole structure of the financing of our federation. Not only do we need to decide what services government should provide, Then secondly, who should provide them, but then how they're to be funded. And that how there is a very big question that neither side is prepared to address. They're both talking about budget surpluses when they're looking down the gun barrel of large deficits, increasingly large deficits going forward. So in that context, to fund any new major initiative is going to take a lot. National disability, only a part of it's funded, and the levy will fund about a half of the full year costs of it. So where's the rest of the money going to come from in 2021, 2022, 2020? These are big numbers, and I think future governments will be constraining it, redefining it, reducing it, targeting it, whatever the word is, rather than being able to deliver against the expectations that have been created in the current environment.
Yep. Tom, you better.
Well, I agree with most of what John, well, almost all of what John said. I just add a couple of things. First, in the context of the three levels of government, and it's probably not as applicable in the territories, but that's an exception that sort of proves the rule. The really big elephant in the room in these fiscal debates is the GST. It's the only tax that you can, well, it's the only tax, it's the tax whose base can be changed or broadened fairly easily, and frankly, and the amount levied can be relatively easily changed. The impact.
I'm glad I didn't have to advocate.
Yeah. I thought I'd let you off the hook.
I was working on it, but
the import of that, which is a very by the way, all jokes aside, that's a very unpopular thing to say. Though I think if you actually led the public through the debate, they'd eventually get it, right? But no one's really prepared to do it. And basically that's because the fundamental problem, which all of you probably have observed, and it makes your blood boil when you're a state minister, especially in one of the big fiscal portfolios like education or health, is that the Commonwealth goes around making all these ideas about how you're going to do it, and the poor old state, as John said, has to go out and find the money, and there is no money. And of course all the money comes from the Commonwealth. They're not going to give it to you. So short of putting up parking fines by $20,000 or something ridiculous, the states are not going to get the money anywhere else except the GST, and that's the fundamental change. You could actually make the relevant change to the GST, and you could actually have a sustainable health system publicly. You probably have to still make some changes and look at some greater private roles for elements of the health system as well, but that notwithstanding, you could still have the kind of health system we have more or less well into the future, and the education system and changes you need to make. So I think that's one thing I'd park as an additional point to John's. But the other thing I think is that you have to make your argument economic. It's one of the things we probably missed out in our assessment that and John alluded to it later on, is that having a financial argument or an economic argument for your initiatives is very important. And we all know that in terms of health dollars, the equations around poor oral health and the implications it has for other chronic illnesses, and therefore the implications it has for cost, and your 55% that don't get adequate dental treatment are the people that are also the frequent flyers in emergency departments and everywhere else, needing all sorts of other government assistance. So, and last but not least, I'll chuck it in, John, so you don't have to say it, got to get rid of middle class welfare. We just have to get rid of all the unnecessary tax breaks so people can afford to look after themselves.
Can I just put some numbers on the GST?
Yep.
It raises about 50 billion today. If you broadened it to everything and you increased it, say, from 10 to 20, the number would be like 140 billion. So you'd have 90 billion more dollars to spend on the sort of things we've been talking about. So I think it's inevitable that at some point when you come to address how you're going to fund these things, nobody's going to want to put up income tax or corporate tax, and both sides of politics are in fact promising reductions. And then, so the only other way to go is to look at where you get the big concessions in the tax system. You get them in housing, $40, $50 billion worth, but nobody's going to tax the capital gains on a family home or even attack negative gearing. So put housing to one side. The next area is superannuation. That's got about $30 to $40 billion worth of tax benefits. They've made such a mess of that over the last decade or so that their reluctance now at political level to deal with that in any objective sense, raise a substantial amount of money from it. You're left with the GST.
Well, I think you've tapped into our electronic wizardry and the internet and the ether and iCloud, because one of the questions that actually came through raised that very issue about will we be moving into the GST as a mechanism of sustaining our new initiatives in education and health services.
That question came from my mother.
Okay. The comment I've also got on my screen here is to advise online participants to keep their questions short. We've got another one here that's online. Reform in the healthcare sector is often driven by understandable desire of governments to make healthcare more accessible. Healthcare professionals often perceive this as lowering the bar in relation to established standards of care. Are they right or wrong? And I suspect the interpretation of this might be the expansion of the numbers of dentists within the workforce, the increase in dental auxiliaries, oral health therapists, dental therapists, as being a mechanism which governments might see as making healthcare more accessible. But what is the impact on standards?
I think this is a challenge for you as an industry, as a profession, to set those standards and ensure that they are what's adhered to when it's made more accessible, rather than let somebody else define what those standards are in the political process, and ultimately they will in fact be lowered, in my view.
Okay, John, do you have anything to add to that?
Probably generally think that John's summary is pretty accurate. I suppose I also assume, you know, that governments, this is not really reform as such. This is the old principle of supply and demand. If dental fees are expensive over time, we get more dentists than we have. We don't have as many costs in the dental area. I don't think that will work. All the evidence from economics, I can't remember, I'm sure John knows the law that says it, that basically the people that are still practicing will maintain their incomes and just more people will not be able to practice. There's a principle that I'm not sure how to summarise it, but I know that's likely to be the consequence of that kind of policy if it is that reason. I thought it was more just that there was a view that there needed to be more practitioners. That's always legitimate if it's so, but I've heard very strongly, I happen to have heard very strongly the ADA argument that that is not necessarily so, given the scale of things that are being proposed.
Right. Do we have a question from the floor at all? Dr. Burgess, you have a question.
It's a labour market law. I can't remember.
Thank you. I'm glad the GST came up because I was going to ask that to Dr. Hewson, given it was something near and dear to his heart 20 odd years ago. From what I understood, you're sort of advocating that perhaps they've got to consider increasing the GST and taking away the exemption from health and education would be something you'd also. Given it's a regressive tax, how then would you compensate that element of the community that already struggles to access dental care? And I guess I'd be interested to hear John Della Bosca's view as a former very good health minister. Yeah, the state... I said that in my presidential message when I left. How would you compensate those that already struggle? So 1 in 3 Australians already struggle to access care. What processes would you put in place?
One of the things I thought I demonstrated definitively in '93 was that, yes, it is a regressive tax, and you start by admitting that. But because of the amount of revenue you can raise, you have the financial capacity to target compensation to those who you want to help. And indeed, you can actually take the opportunity of fixing some wrongs, if you like, in terms of the welfare system. For example, the impact on pensioners in '93 was going to be about 10% in terms of the average pensioner's expenditure budget. And I was going to double their pension. Okay, so I could more than compensate them and fix what was a really significant inequity in within the welfare system, that the pension was too low. And the same you could do today with the New Start benefit if you were doing it, for example. You have the financial capacity to do that, as well as fund a number of these other structural things that we've been talking about. And that's why I think that although it's easy to run the argument about it's being regressive, I think you just start out in politics by saying, yes, if I do nothing else it is, but I have the capacity to compensate, and these are the people that I want to compensate, and this is how much I'm going to give them. And you can make that quite explicit. And even we did very tight numbers in '93, and something that people don't know that we did was to under-promise. If I thought the revenue from the tax was going to be 100 billion, I made it 80. I put 20 in my back pocket, so I thought if I ever got into government, I'd be the first Prime Minister who over-delivered, because I could actually pay out more. And you have that capacity if you are making that sort of substantial structural change. Now, it's never going to be easy to say, let's put it on everything. Put it across health and education, for example. Let's increase the rate. But I agree with John. If it's carefully handled and explained, I think you can achieve it, because the alternatives are actually awful in terms of trying to continue doing what we're doing, which is grinding all the quality of our infrastructure down, and failing to match any of the expectations that are being created, or any of the other alternatives like taxing the family home. I mean, that's going to be a pretty big issue, and that won't raise you anywhere near as much as what I've just said the GST will do.
Anything further to add there?
No.
All right. We've got another question online from Dr. Peter Fulton, who asks, successive government inquiries have failed to adequately address the emerging dental problems of an ageing population. How does the profession impress on the general public that we are nearing a dental Armageddon with respect to the costs of aged care? Who wants to tackle that one? It probably falls a little bit into the disabilities camp there.
Yeah, well, I think I'm just trying to think of I think the underlying point there is successive inquiries have not thrown up a solution. I suppose maybe the suggestion is it's because they haven't actually properly examined the issue. So if you can't, it really means then, I suppose that one option, I'm not saying it's the option you would necessarily pursue on reflection, but one option the ADA would have would be to actually require their own inquiry, or require an inquiry where basically the ADA writes the terms of reference to government. Now that's the kind of lobbying exercise you can probably pull off over time in that kind of sustained kind of way, not necessarily as an election thing, but as a kind of point of saying a repetition, creating another sort of campaign principle is to create a resonance. You can call it repetition, but that's a cruder version of it. You've got to sort of strategically pick your repetitions so that it actually gains a resonance with the culture, what the population is likely to think anyway. So everybody kind of is starting to understand that they're going to get old, and everybody's understanding that, well, the alternative is pretty grim, so they'd rather get old, most people. And they're understanding that, more and more baby boomers, parents are now in their 80s and 90s, and so people understand that that's a live issue, a real issue. They don't know what to do with they don't know how to resolve some of these situations, particularly if they're not well healed. So I think that there's that opportunity, but it needs to be planned as a strategic exercise. And if you're not getting the right result from the current government inquiries that have existed because they've been too superficial or they haven't asked the right question, you have to work out what question you want answered and then go to government over time with a plan to have that inquiry. The second option is to do what John Hewson does and go and have your own inquiry. Hire Access Economics or somebody to do it.
Yeah.
So, well, you needed the authority of an independent assessment is what we needed at the time to win the argument. Look, I think that our society is behind the game in terms of the significance of ageing and the challenge of ageing in so many ways. We see it in relation to residential aged care, we see it in relation to the adequacy of pensions, we see it in relation to superannuation, the preparedness of superannuation. And the number of people over 65 doubled in the last 10 years and going to double again the next 5 sort of thing. It is accelerating away for now, and we have not adequately prepared as a society for that. And an important part of that will be dental health. And the costs of that tend to run away as people get older. I don't know whether what expectations the community really has about what dental health care should be for somebody aged 60 or 70 or 80, but these are questions that I think as a profession you've got to answer and help government through that, because they aren't on their own bat, off their own bat, I think, ever going to actually make the right assessments there.
Right.
When you see these intergenerational studies that have been done and released at the time of the budget and never reflected in that budget or any other budget since. They've been done by the government, they've been ignored by the government, and the problem is just getting bigger every day.
Well, thank you for those very reassuring comments
that's right.
on an ageing population. We have another question from the audience. Dr. Sabrina Manicum, I think, has got a question. Sabrina.
Thanks, Clive. Gentlemen, my question is that in recent years there's been an increasing debate about the commodification of healthcare, where patients are referred to as customers or clients, and healthcare providers or healthcare professionals are referred to as providers. Now, leaving aside the influence of government, dentists are concerned about the influence that private health funds and corporates, large corporates, have over them and their patients. Now, is this a realistic fear that we have, or is this just a necessary evolution of our profession?
Well, I think it's probably a realistic fear. I don't really, personally, I don't like the idea of my healthcare being treated as a commodity, though I recognise, people have got to charge fees, or someone has to pay, an insurance company or the government or somebody. But at the end of the day, we all kind of think of these things as very personal, and much more personal than buying Vegemite off the shelf at Woolworths. So, whether it's dentistry or whether it's the sorts of services you go to your general practitioner for in medicine, then you, I think, expect a kind of level of personalisation, which means that sort of commodity approach isn't right. Of course, though, and I speak as a former health minister, the need to find ways to control cost and to match cost to performance, in the public hospital system for a start, and some of you would have some experience with the public hospital system, is a huge challenge and very difficult. And the way, you're referring to a pattern of things, which is that whether it's managed care in the insurance context or kind of I suppose bureaucratised care in the public context, what you're getting is sort of the issue of the professional being controlled, as if they were a panel beater or somebody who you couldn't decide exactly what how long it should take them to do various things and all that. So that whole kind of model, I think, is very challenging for the health professions because healthcare is so personal. On the other hand, I know that we have to have solutions around cost, and that's in the public arena, and I suppose inevitably insurers are going to do the same thing in the private arena. The irony is, of course, people tend to think it only happens in the public arena, but it happens even more in the private arena.
John.
Look, I must admit a few years ago I got particularly offended when I read the annual report of the tax office, tax commissioner, and he referred to us as clients. I never thought of myself as a client, and I got even more concerned when I saw that his mission statement was to maximise revenue. I thought we were funding them. But that process has existed through government, and it's a very difficult one because from the point of view of defining benefits, targeting benefits or services, it naturally leads to some level of commoditisation of the process. And it comes back to the individual practitioners, I think, to make you feel important as a patient. Now, you can go to different sorts of medical centres and makes the point. Some of them are just bulk billing centres where they just pound you through every 10 minutes and they say very little and pay very little attention to you as an individual, as distinct from others who you can actually happily treat as a family doctor, and you all go along and they all know you and they've all been part of your life for quite some time. And a lot of that comes back to the way the same service is actually being delivered by the two sets of circumstances. And I see that that's a bit of a challenge. And while to the extent that government or private health funds are funding the provision of these services, they're naturally going to have to define them, and that leads to that commoditisation. But you can't let that attack what you consider to be your relationship with the patient. And I think you can draw that distinction, but it's easy to get swept along with it, and I think that's a danger. And I think it is true that although you can standardise the costing of that treatment, for example, everybody is individual in terms of the nature of their care. All the teeth are not the same, all the mouths are not the same. They need to have that sense of you are concerned about them and how you're treating them, as distinct from the fact that you may bill it out in another way.
Thank you very much for that. We've got a quick online question. Well, it's a longer question, but it'll be, I think, some quick answer to it. Dentistry has been at the foremost amongst the professions in regard to continuing education, and the profession can proudly claim to be amongst the finest in the world. Now the government has shown its total disregard for further professional education by limiting the amount of tax deduction further education to $2,000 per annum. On top of this, there are plans to allow lesser trained auxiliaries to practice in their own right. Surely this demonstrates that government's attitude to dentistry and demonstrates they prefer cheap dentistry to quality dentistry. How do you counteract this attitude? And it's from John Byrne.
The auxiliary issue, of course, I think is a tricky one. But again, if it's about motivation. If the procedures that's been proposed for auxiliaries to perform are contrary to the interests of patients, then dentists should say it loud and long and hard and focus on that as the issue. It's not really an issue about whether dentists will have X number or Y number of patients or be doing X number of procedures, but the question is, is allowing auxiliaries who only have this much training to do these kinds of procedures, is that unsafe or potentially detrimental to patients? And I think if you stay with that focus, that's the argument to make, and the argument you can win in the public arena and elsewhere. I think with the other argument, which is the tax one, I think that'll get handled. By the way, I think that'll end up being all right. But I'd caution the ADA or the AMA or anybody about going hard on that because it doesn't look good. Because very few other occupations, dentistry, medicine, maybe some engineers, maybe lawyers, they can all do it. Most punters out there don't. And the idea of it being limited to $2,000 would make a lot of people's hair stand on end. And by the way, I'm almost certain that it'll get changed.
On the first part of the question, I'll go back to my comment before that as a profession, you set the standards and you've got to be seen to set them and fight for them and enforce them and fight against what you perceive to be a dumbing down of your profession. And that's not an easy fight to win, but it's one that you've just got to fight for, I think. On the education allowances, look, I think you need to simply decide which fights you want to enter, which battles you want to fight and which ones you don't. And right now, I agree with John, that one is not worth fighting. Yeah. I don't downplay in saying that the significance of the education function, and I think you've got a great track record of having done that, but we need to crank education up as a positive. A few years ago, somebody promised an education revolution, and we're going backwards. So there's a long way to go.
All right, well, we won't move forward on that one any further then. What we will move forward on is our time, and we've got a number of questions from the floor, but I think we've got to wrap it up, so I'll ask Dr. Matthew Fisher to pose the final question and then ask Dr. Lynn to give a vote of thanks to the speakers.
Thanks, Clive.
Matthew.
Both to the two Johns, firstly, you've embraced many issues that have challenged us in our thinking. So my question really to you, that you can put either to the individual practitioner who might be in the room or listening to us, or to us as the association representing the majority of practitioners, what is the key take-home lesson you would like to direct back to the individual or the association with regard to its relevance?
You're about patient care. That's it. I think dentists are about patient care. People don't understand that as you might think they do. That needs to be repeated a lot, and that your reason for advocating things at the end of the day is always about patient care. That would be if I was advocating a takeout, that would be what I would think was the best takeout.
Yeah, I think patient care and improved dental health for all Australians. I mean, I would plug that as, and you deliver that by patient care.
So thank you very much for that. You've wrapped up on a go back to your knitting principle, and also stick with dentistry and its public weal, spelt not with a W-H-E-E-L, but the W-E-A-L. I'd like to pass over now
Thanks
to
very much, Craig.
Tom Lynn to propose a vote of thanks. I'd also like just to make a quick comment to those that are online, that I know that there are some further questions out there. Thank you for your participation, and we're sorry that we've run out of time here now. So thank you, Tom.
Thank you. What a fascinating presentation, ladies and gentlemen. It's my pleasure to thank our panel, Clive Wright, John Della Bosca and John Houston, for attending and giving us their perspectives coming from dental, political and economic backgrounds on the discussion topic of the meeting, how relevant the dental profession is to the general public. If the general public do not consider us to be relevant, then there's little chance of good dental health for our community or a future for our profession. This discussion, as you can all appreciate, is very timely and important with all that has occurred and is currently occurring in the dental landscape. Among just some of the issues you are aware of is the recent closure of the chronic disease dental scheme, the long waiting lists in public dental clinics, the provision of new agreements for publicly funded dental services for disadvantaged children and adults commencing next year. And of course, we're all familiar with the current oversupply of dentists, which is resulting in a lack of busyness for many of our colleagues. At the same time, this oversupply of dentists is now leading to an improvement in the availability of dental services for rural and remote areas. This then begs the question of why, most recently, the Dental Board of Australia is having deliberations on the extension of scope of practice for dental auxiliaries. One cannot say that we don't have a mile of issues confronting us now and for some time in the future. We have been very fortunate, however, to have had this opportunity to listen to these three distinguished presenters giving us their informed professional insight on the topics. This discussion will no doubt help us keep our eye on the ball and on the game plan to provide a grounding from which we can draw on for our blueprint for our future. Congratulations and thank you very much, gentlemen, for an excellent presentation. I thoroughly enjoyed listening to you, as I'm sure as our audience did. And if I may stretch a friendship and ask you that we may invite you sometime very soon in the future once again. Thank you again.
Great, thank you. That's good, thanks, John.
Thank you very much.
Sorry.
That was great.
Funny. Thanks, Clive. That was great.